Chapter 39, Thrombotic Disorders and Laboratory Assessment. So we'll go over the thrombosis risk and testing that's done for it, what causes it, how often it happens, what are your risk factors, how we determine what thrombophilia is by laboratory evaluation, and arterial thrombosis predictors. Plus, we'll get into the venous side of it, DIC, HIT, thromboinflammation, and the future of all the different testing that's involved. So the testing for thrombosis, what we have to look for is things that would normally should regulate the clotting process. In other words, antithrombin, protein CNS are very good in stopping the clotting process. So if there's something wrong with them or issues with them, then we're going to have an increased chance for having clots, thrombotic issues. So the current issues, factors that we have now are factor V Leiden mutation, the prothrombin 2210A mutation, lupus anticoagulants, antiphospholipids, and D-dimers is one of the big things that we actually will run into to give us a risk for thrombosis. So what is the cause of all this? Well, there's something wrong with the coagulation system, be it a platelet function pathway, white cells getting inflamed, the vasculature is messed up, something like that. So what's happening is we're having platelets clump or fibrin in there causing clots, and what it does is it blocks the either venous or arterial area. So when it does that occlusion or obstructs it, then we get a backage of the blood. It's called ischemia. And because of that, oxygen can't get forward of where that blockage is. So then we have necrotic tissues happening there. So we have thrombosis. So this is where we're having the clot formation, be it platelets or fibrin, blocking stuff. People can have what's called thrombophilia. In other words, they have increased chance of clotting, called hypercoagulability. For some reason, they just clot like crazy. So what are the reasons for that? Well, there's a ton. Most of them are due to some kind of acute or chronic inflammation, is usually the biggest cause of that. And what causes the inflammation? Could be some kind of physical, chemical, or biological. Don't know. A lot of things can cause that. And when that inflammation does happen, we'll get release of thrombotic stuff in the system. And when that happens, we'll get massive platelet activation or activation of the coagulation pathway for things that should not normally be there. And if we have deficiencies in like protein CNS or antithrombin, as per example, then we'll have problems with controlling the clotting, and we just clot like crazy. Other things is that we can't dissolve the clots. So we have fibrinolytic issues that we can't dissolve the clots like we should. So one of the more common ones we run into is venous thromboembolic disease, VTEs or DVTs. So this happens very commonly. You can see the numbers there. Women of childbearing age is very common, African Americans. And what happens, we get deep vein thrombi, and it's usually in the iliac popliteal, like around the hip area. Could happen in the calves, upper leg. But usually they have pain. It's red, puffy, swollen is usually what will happen. A side effect of these clots is they can break loose, and then they can go to the lungs and cause pulmonary emboli. Then they'll have problems breathing. So we have massive issues with that. Now the risk factors, some we can control, some we can't. For instance, weight, smoking, immobilization, hypertension, high cholesterol, the bad kind of cholesterol, and diabetes. Age is another thing, which, that just comes with it sometimes. So all those risk factors, the more risk factors a patient has, the increased chance of thrombotic issues to occur. So chronic inflammation, in other words, constant injury to the inner lining of the vasculature, the endothelial cells. So we have increased chance of clotting called thrombophilia. So if we have these coagulation imbalances, in other words, we're getting the coag factors are activating for some ungodly reason, we don't know why. We've got too much thrombin being formed, and we can't control the clotting, and then the fibrinolysis is not there. So one of the things that I said that you can't control is if the patient has cancers, heart or lung or kidney issues. Any of those, they have an increased chance of venous thrombotic disease. The other side of it, other than the venous, is the arterial. So the arterial thrombosis is very quick, can be fatal, and has to be found quickly. Heart attacks, myocardial infarctions, strokes, TIAs, transient ischemic attacks, peripheral arterial diseases, any of those. So now we're talking about the arteries have clots in them now. So what causes that? One of the main reasons for those kind of clotting episodes is sclerotic plaque in the arteries. So we have plaque buildup, and it's because it's unstable. In other words, it fractures. So it's like a sidewalk breaking apart in little pieces. And when it breaks apart in little pieces, that will activate the platelets, some white cells. What will happen is the endothelial lining now gets messed up. So now we get release of antithrombotic molecules. Nitric oxide should be there. Tissue factor will become exposed. So now we start getting clot formation. So as these little rupture of the plaque happens, it will cause a clotting and will block smaller arteries. For instance, the coronary arteries around the heart or in the brain for strokes, TIAs, that kind of stuff. So you have to be careful with that because when it's arterial, you got major problems and it has to be handled quickly. So this is in your book. Again, this is some of the factors that we were talking about: age, immobilization, hyperlipidemia, oral contraceptives, pregnancy, hormone replacement therapy, fractures in the femur of the tibia, surgeries, and you can see a whole bunch of them listed there, smoking, inflammation, and venous catheters. So when you look at that, you're like, my God, that's almost everybody's got something in there. So that's why it's such a big deal to try to control this. So the thrombosis risk factors, you can click on that link. This is actually the thrombophilia website that talks about the acquired thrombosis risk factors that we run into. And it tells everybody that what the risk factor does and how it increases your chance for clotting. Now this is also, like we talked about with inflammatory deals, talking about systemic diseases. One of the big things is autoimmune system. So if we have antibodies against our own body, one of the major ones that's produced is an antiphospholipid. And this antiphospholipid, in other words, we're talking about the cell walls. So anytime you have antibodies against that, you're going to cause inflammation when the endothelial cells get inflamed. Other things is cancers. If there's cancers, we got an increased chance of clotting occurring, and that can cause full-blown clotting everywhere, which is DIC, disseminated intravascular coagulation. The number one problem cancers that we run into is colon and pancreatic cancer. Other ones is all the myeloproliferatives that we talked about. ET, PV, APL, DIC, PNH, paroxysmal nocturnal hemoglobinuria, all those. Now, there's anything messing with the activation of the platelets. If it allows them to be super activated, then we got a chance for clots. Then we have chronic inflammatory diseases that we just talked about. Diabetes is a big one. Atherosclerotic plaque formation, atrial fibrillation. And then you've got kidney issues. In other words, we're losing the proteins now that should normally take care of the clotting. And now we don't have them there. So if they're missing, then we're going to run into issues. So these are the diseases where thrombotic risk components that we were talking about, the antiphospholipid syndromes, the autoimmune disorders that we're doing. So, and you can see the testing that's done, like PTT analysis, lupus anticoagulant pathway, the myeloproliferative neoplasms, looking for platelet activation, platelet aggregometry, hepatic disease, where the factors are produced. So then we got to look for protein C's, all the different factors, protein S, antithrombin, all that. Cancers, increased chance of DIC. So we have to look at the platelet count, PT, PTT, fibrinogen, D-dimers, look for schistocytes. Leukemias, like we said, APL, acute promyelocytic leukemia. Big chance of having DIC with that. PNH, again, another risk factor for having platelets being activated where they shouldn't. Chronic inflammation and then thromboinflammation. So we're talking about the vasculature being messed up. There are some congenital issues that we run into for thrombosis. Clinical features, in other words, family history, something with their veins, kidney issue, intestinal issues, any of those kind of clinical things. Then inherited antithrombin deficiency, which should block 1, 2, 2, 9, 10, and 11. Protein C deficiency, protein S, factor V Leiden mutation being inherited, prothrombin G2210 mutation being there, inadequate folate, which causes hypocystinemia, and that will, or homocystinemia, which will lead to decreased amounts of folate, which then will actually make us have more cholesterol, the wrong kind we need. Hyperfibrinogenemia, too much fibrinogen in there. And then a lot of what happens congenital is that you inherit it, but we don't see it yet. And then say it's a female and she gets some birth control pills. They call that the double hit. In other words, you got double the chance now of thrombosis. So here is just looking at all the predisposing factors that we just talked about and the testing that has to come with it. So you have to really narrow it down quickly to figure out what's going on with the patient. So to do that, the laboratory tests that are done is if the patient is on anticoagulant therapy, which I can't spell therapy right there, but you have to make sure they get off of it. Once they get off of it, then we can start doing testing because that's going to affect all the results. Do they have antiphospholipid antibodies? In other words, do they have antibodies due to usually autoimmune disorders? Then that will cause problems for increased inflammation in the vasculature, increased chance of thrombotic issues. Other things that we see with people that can have these antiphospholipid antibodies is if they've got septicemia. In other words, they've got some kind of bacterial, viral, fungal thing going on in their bloodstream. Certain drugs can cause it, and then you can see a list of the autoimmune things that are out there. So one of the big things that we actually do is we can actually check for lupus anticoagulant. See, what has happened in the lupus anticoagulant is that the autoantibody to the phospholipids that we have is actually affecting the activator we use in the PTT reagent. So it can't activate it as fast as it used. So it takes a lot longer. Hence, the PTT is prolonged. And then we have immunoassays for cardiolipin, anti-beta 2 GPI, antiphosphatidylserine, which we'll talk more about when we get actually in immunology. So one of the things that we run into a lot is APC resistance, activated protein C resistance. Because remember, protein C is supposed to inhibit factor V and factor VIII. Now what happens if they inherited the Leiden mutation for factor V? What it will do is it will not respond to protein C. And because it does not respond to protein C, then they'll have an increased chance of clotting. So we can do mixing studies. We can actually do the factor V Leiden mutation, which is a molecular test that will determine that. That's the best way to go for that. Prothrombin G2210A is actually a mutation in the prothrombin itself, and it won't respond to using antithrombin. So we have an increased chance of thrombosis. The proton levels will actually be prolonged, but the best way to do it is molecular testing. Antithrombin, remember we said it neutralizes thrombin factors 9, 10, 11, and 12. Works really good for that. It actually works with heparin. Now, some people can get acquired deficiencies because they've been on prolonged amount of heparin therapy, or low molecular weight heparin, unfractionated heparin, synthetic heparin. So we can actually have acquired deficiencies because there's so much heparin that's been going on. That's why a patient cannot be on heparin for prolonged periods of time. There can also be congenital deficiencies. Could be they've got liver issues, could have kidney issues, or they could be on oral contraceptives. So there is testing that can be done. It's a clot-based method is what we've been doing in the lab here. We actually have a chromogenic, which is a color method to look for it. Or there can be immunoassay methods. So there's multiple ways we can assay for antithrombin, because we got to look to see if the antithrombin assay looking for the resistance due to heparin, because antithrombin becoming depleted because of so much heparin in the patient. So protein C control pathway, remember, is big, and taking care of factor 5 and 8 is one of the big things that it's after. So its role is trying to prevent thrombin a lot of time, because remember, thrombin will cleave fibrinogen. It goes through all those factors. And thrombin can act as an anticoagulant also, because it interacts with what's called thrombomodulin. Thrombomodulin is part of the endothelial cells and will actually help in preventing clotting. It also, works with protein C to actually help protein C, the thrombomodulin complex, to make sure we have it to control the clotting. Protein S is like a cofactor sorta that goes in with protein C, and it will help bind with protein C so it will become activated. So the coagulation factors that are controlled by the activated protein C and protein S is factor 5 and 8. If we stop those, decrease those, then the thrombin production will be decreased. Now, what happens if you don't have the protein C? Well, what will happen, you have TIA strokes, DIC, and that can happen, especially a double hit kind of deal, if they aren't oral contraceptives. Sometimes we do see it in people that have vitamin K deficiency, and that usually occurs from a lot of intestinal surgery. They can't absorb the vitamin K like they should, or if they're on prolonged antibiotic therapy that's wiped out the normal flora in the GI tract. So to assess for protein C and S, we can use chromogenic or immunoassay testing for that. So again, here's the coagulation pathway. So you can see how we activate it, and you can see, thromboplastin, tissue factor coming in. But what's important here is showing us how protein C and protein S become activated and actually will inhibit 5 or 8. Or we can have antithrombin doing 2 and 10. That's the two biggies that it goes for. And plasminogen with TPA making plasmin to dissolve the clot. So this is a good flow chart to look at that, to try to get that in, to understand what's going on. So here is the thrombophilia laboratory testing profile. So, we start with the basic PT, PTT. We see they're having clots. So then we start doing testing. A lot of it is molecular testing that we have to find out what's going on with the patient to identify what the problem is. So the traditional predictors we look for is cholesterol. We look for how high the LDL is and the HDL. The higher the LDL, the worse. The lower the HDL, bad. So that has got to be, something that has to be looked at by the physician. And it's not an easy fix. It takes time. So the current predictors that they look for arterial thrombosis is lipoprotein A. It's a type of LDL, and it's an enzyme immunoassay method. It has a very high antifibrinolytic activity. It actually will compete with plasminogen for binding to the fibrin, so it decreases plasmin activity available for fibrin degradation. So we have problems with that. C-reactive protein, really HSCRP. It's a very good marker for telling us about inflammation of the endothelial cells. It can pick it up really quick. And then just doing fibrinogen activity. You know, we're going to be using the clot-based method, but there's immunoassays or nephelometric. Either way, you can do that. Plasma homocysteine, which is a good indicator of coronary arterial disease. And then factor VIII, which is another acute phase reactant, telling us about acute inflammation. So watch that DVT video, because deep vein thrombus symptoms, again, is usually pelvis, thighs, calves is where we usually see it. Red, puffy, swollen, hurts, you know. And then if it goes into the lung, we get pulmonary emboli, PE, then they'll have problems breathing, they'll be short of breath, they'll have little fainting episodes, tachycardia, all that can happen. So what we do a lot of times is we look for the D-dimer, because a D-dimer will tell us if they're breaking down clots. All right, so it can be a monoclonal antibody test. We'll actually be doing that in labs, so you can see that also. Very good test to do. Which brings us to DIC. DIC is where it's called a consumptive coagulopathy. In other words, where clotting has initiated and we're using up the factors like crazy. We're eating up platelets, eating up fibrinogen, everything is going like crazy. So usually every system's involved. It's usually in the small vasculature. That's why they call it microangiopathic. So what will happen is they start bleeding like crazy because they're clotting like crazy because they're using it up like crazy. So it can be an acute thing. That's usually what it is. It can happen chronically, but that's not as full-blown as the acute. So you have to sort of monitor it for that if it's chronic. So in the bloodstream, we'll see the schistocytes, and then we'll see the D-dimer elevated. Usually there's an increase in tumor necrotic factor, and then you see the interleukins there. So what causes DIC? Any disorder screwing around with the hemostatic molecules. Anything. So we've got tissue necrosis, sepsis, kidney, liver, any kind of prosthetic thing in a patient, tumors, cancers. You know, that's just chronic. So, you know, there's a lot of people we're talking about here. Acute could be obstetric, where the placenta, when it's coming away from the uterus, can cause it. Intravascular hemolysis, septicemia, viruses, burns. I mean, look at it. It's just a list. It's amazing. It's like, my God, there's so many people could be affected by that. So, here's this thing here, and it's basically what we had just said. It actually came from another book, but so you can see a picture of that there. So DIC. So we initially will do a platelet count is decreased. We see schistocytes. PT and PTT are very prolonged. Fibrinogen's down. D-dimer is increased. So it's consumptive. It's using. So we look for the protein CNS, and antithrombin is decreased because it's been used up. So how do you treat it? Well, you got to take care of the underlying disorder. I mean, we have a lot of things that cause that. So they might have to have surgery. It might be on antibiotics. A lot of things have to be done. Something to control the inflammation. So sometimes we got to slow that clotting process. So one of the big things they give, which seems odd, but heparin. If we stop the clotting, then we can slowly bring this under control. And then you'll have to give replacements for the coagulation factors and the platelets. Fine line on how we treat that. So heparin-induced thrombocytopenia, in other words, the platelet count is decreasing just because the patient's been on heparin. And it's usually because the patient has developed antibodies against the heparin therapy. The longer they're on it, the worse it can be. So what happens if we have heparin-induced thrombocytopenia? Well, we got an increased chance of thrombosis, be it arterial and venous. So now the platelets become activated. The antibodies will bind to the platelets. They release their stuff, which we'll see here in a second. But what you can see is their platelet count is just slowly dropping every day. So there is a special test that we can do for it, immunoassay test for HIT, but platelet aggregometry is good for that. So what you have to do is get rid of the heparin, stop it, and you can give alternatives like fondaparinux, which is a type of synthetic heparin that you can actually give a patient. So this is showing you heparin, okay, the platelet factor 4, and then the IgG, okay. So then we can see the formation. What will happen is platelets become activated, they release their stuff, okay, so platelet factor 4 comes out, it keeps continuing heparins out there, it forms complexes with it, and then we actually have more platelet activation. Platelets aggregate, causing thrombocytopenia, huge inflammatory process going on. So what's thromboinflammation? So now we're talking about the endothelial system, the very basics of primary hemostasis. It becomes damaged, so that will get the platelets going, which then gets the coagulation system going, which then, because of inflammation, will get complement. Because of all that, then all the cytokines, cells, talking to each other. What causes that? One of the biggest ones that we ran into just recently is COVID-19, the SARS-CoV-2. That caused what was deemed a cytokine storm, massive amounts of inflammation because the body was trying to respond to it. And this is how they figured out how to treat it to keep the patients from dying, because we were having massive thrombosis because the platelets had been aggregated, had been stimulated. So there is a significance in the vaccine-induced immune thrombocytopenic purpura. So for some, or thrombocytopenia, what is happening is some people, very small amounts, but we have seen some people can get thrombocytopenia due to the vaccination. So how do you treat it? If we know about it, we can treat it. You can give anticoagulants, or you can give intravenous immunoglobulins. They call it IVIG, is a good treatment for it. So thrombosis risk testing, what are we doing now? Well, the best thing now is we have to assess the risk, look at all the risks, see what's going on, diagnose all the other problems they could possibly have, and then we have to monitor the treatment. Find out what needs to be done, diagnose it, and then you got to constantly evaluate these deficiencies to make sure we know what's going on. So for us, we have to have better ways to detect chronic and acute inflammation. We have to get better ways to determine if the endothelial cells, if they're inflamed or not. The HSCRP is a great way to do it. Molecular diagnostics is helping us understand what it is, and then we have to do like hereditary genomic studies to figure out what it is, learn more about the cytokines. So make sure you look at what diseases that cause that. What are the inherited things? What are the #1 reasons traditionally why people have arterial problems, venous problems? And what is the testing we do for that? So look at the chapter, make sure you do the questions, and we'll talk about this in class. Thanks.